What is the history of PTSD diagnosis? Imagine a time when soldiers returning from war were seen as simply having nerves or weakness. The story of how post-traumatic stress disorder became a recognized mental health condition is a fascinating journey through history. It all started during the First World War, when soldiers showed symptoms like trembling, fatigue, nightmares, and trouble concentrating. Doctors called this shell shock, or disordered action of the heart, thinking it was mainly caused by physical injury or the shock of explosions. Similar ideas persisted into the Second World War, with terms like battle exhaustion, war neurosis, or combat fatigue used to describe soldiers overwhelmed by stress. These early labels reflected an understanding that trauma from combat could cause real psychological symptoms, but they also suggested that recovery was usually quick. In the 1950s, psychiatry began to recognize trauma-related reactions more formally. The American Psychiatric Association included gross stress reaction in the first edition of the Diagnostic and Statistical Manual of Mental Disorders, known as DSM-1, published in 1952. This diagnosis acknowledged that people could develop psychological problems after traumatic events like war or disasters, but it assumed these symptoms would resolve within 6 months. However, by the time of DSM-2 in 1968, the term was removed, and the focus shifted to a broader category called adjustment reaction to adult life, which didn't fully capture the long-lasting nature of trauma symptoms. The real turning point came during the Vietnam War era. As more veterans returned with persistent psychological issues, along with research on Holocaust survivors and victims of sexual violence, it became clear that trauma could cause long-term mental health problems. In 1980, the American Psychiatric Association officially introduced post-traumatic stress disorder as a distinct diagnosis in DSM-3. This was a major milestone because it recognized that trauma could lead to enduring symptoms that might not resolve quickly and could appear long after the traumatic event. The criteria for PTSD were based on scientific studies showing that trauma could cause chronic psychiatric symptoms, not just immediate reactions. Over the years, from the late 1980s through the early 2000s, the diagnosis was refined with updates in DSM-3R, DSM-4, and DSM-5. These revisions helped clarify what symptoms to look for, how to define traumatic events, and acknowledge that PTSD could sometimes have a delayed onset. That means symptoms might not show up immediately but could emerge months or even years later. The latest version, DSM-5, changed some terminology, like replacing delayed onset with delayed expression, to better reflected how symptoms can develop over time. Initially, PTSD was mainly associated with soldiers, but research expanded our understanding. We now know that civilians can develop PTSD after experiencing sexual assault, natural disasters, terrorist attacks, or other traumatic events. This broader view emphasizes that PTSD is a neurological and psychiatric disorder that can affect anyone exposed to trauma, regardless of their background. Studies also show that PTSD can be chronic, lasting for decades or even a lifetime, with symptoms coming and going over time. It often occurs alongside other mental health conditions such as depression, anxiety, or substance abuse, which can make diagnosis and treatment more complex. Recognizing this history helps us understand how far we've come in understanding trauma and its effects. Today, PTSD is a well-established diagnosis based on decades of scientific research, highlighting the importance of recognizing trauma in many different populations and providing effective, evidence-based care. If you or someone you know is dealing with trauma-related symptoms, consulting a healthcare professional is always the best step to get personalized support.